mastitis can give us very high PSA. But more in favor, most likely, tender. Very tender. Yeah. Okay, let me just yeah. It is tender. Right. Then, what is the next line investigation? So, you are suspecting metastatic prostate. What is the next investigation? How? What are you doing? Trans-abdominal, trans-rectal, ultrasound guided. How many courses will we take? How many courses? 12 courses. 12 courses. What is the scoring system that you get?
Patients. Making grading. Lesions, SimScore.
Have you seen Gleason score reports? How does it give? How much then you value?
3+.
Yeah. One number and plus another number. That is depending on the histological predominance. So, when it is 8, 9, 10, it is highly malignant. 7 is the borderline. 7 can be 3+4 or 4+3. So which one is more malignant? 4+3 is more malignant than 3+4. 6, there's a huge debate whether 6 should be considered as malignancy. Gleason 6, because they don't die of malignancy basically. They can die of other problems. So, huge debate. That's why the prostate carcinoma screening protocol is not well established, because there's a possibility of overdiagnosing patients. So, nowhere in the world it is a well established screening protocol. So we have clinical malignant prostate, we have very high PSA, then we do trans that also confirms. Any other way to prove metastasis? How do you prove metastasis? X-ray can only suggest. Do you see anything abnormal here? Yeah, that imaging is not suggestive of this. This could be a sclerotic area, but not very suggestive. You need a bone scan. Technician might isotope bone scan. If it shows multiple uptake, that is suggestive of bone mass. Also bone. Sometimes you see the entire skeleton is darkened. That is called bone super scan. Go on. Right? The patient has bone pain. What it means? Is there bone pain? What is the characteristic of bone pain? Malignant metastasis disease? Pain at night. Disturbing sleep. Simple analysis, not really by the simple analysis. And is it a generalized pain or more localized pain? Yeah. Localized, excruciating pain, especially at night, disturbed sleep, does not relieve by simple analysis. You have to tell all these points. That is the bone pain, typical bone pain. So then this patient has, we have clinical examination, biochemical marker, imaging, and histology. If you have 3 out of 4, you can label this patient having metastatic prostate CA and go ahead with treatment. What is the treatment for metastatic prostate CA? What is the treatment for metastatic prostate CA? Don't do anything. Give analgesics. Gabapentin and discharge. Metastatic prostate CA. Growth depends on what hormone? Testosterone. So what you should do? Yeah. So androgen ablation. There are 2 ways: medical and surgical. Surgical androgen ablation is unilateral located. Bilateral located. Then
medical.
Anything else? Any other options? How do you medically castrate a patient? Huh? GnRH?
And agonist.
Antagonist. So antagonist cannot be given. Yeah, antagonist is also an option, but we don't use it much. Right? Or GnRH analog, which is commonly used. Tell me example. Finasteride? Goserelin and buzarelin. Goserelin and buzarelin are the drugs. So when you give it, it's an agonist, so it stimulates initially, so there is a testosterone surge. So if the patient has bone mets with impending collapse of the vertebrae, it can precipitate the vertebral collapse and spinal cord paralysis. So therefore you have to be very careful when you are given GnRH analog. Initial period has to be covered with anti-androgen to cover up the testosterone surge. Anti-androgens can be finasteride, flutamide, cyproterone acetate, anything. So you give all these two combinations, that is combination of GnRH agonist with anti-androgen is called total androgen blockade. So that is a medical castrate of the patient. Apart from that, patient should be given painkillers, so your other care. And if the patient has a long bone involvement with a metastatic deposit, you can do fixation orthopedic orthopedic interventions, and there's a place for bisphosphonate. Bisphosphonate. Tell me bisphosphonate that you know. Alendronate. You can't forget your pharmacology. So bisphosphonate. What is the action of bisphosphonate in metastatic bone disease? It is tumoricidal. It has anti-osteoclastic activity. Right? It has anti-osteoclastic activity, but it does not prevent the progression of the disease. These all can be MCQs. It does not prevent the progression of the disease, but it reduces the risk of vertebral and non-vertebral fractures. It reduces the risk of hypercalcemic events. Right? So when there is a metastatic bone disease, there can be hypercalcemic crises. It reduces the risk of hypercalcemic events and those things, and it has anti-tumor activity. The drug of choice is IV zoledronic acid. IV zoledronic acid, once a month injection. I can't remember the dose, maybe 1.5 milligram over 4 hours, something like that. Given in infusion over 15 minutes, and then you have to keep the patient hydrated on that day, and you can discharge once a month injection. So it has action. So that's how you manage. And remember, now I told you medical castrate and surgical castrate. Advantage of surgical castrate is they respond very quickly. Now say a patient has bone pain today, severe bone pain, if you do bilateral orchidectomy, by tomorrow patient will be free of symptoms. Right? Then the other one is drugs. Drugs take some time to act. It takes about maybe 4 weeks to act. Right. There's a place for GnRH antagonist also, not commonly used. The other thing is bilateral orchidectomy. It is irreversible. Whereas GnRH drugs is a reversible one, because some patients do not respond to this castrate. Some patients do respond. So let's say, how do you know the response to androgen ablation? How do you assess the response to androgen ablation? Response can be clinical, biochemical, and radiological. So clinically, patient will be free of pain, as I explained. Biochemical, your pace is drastically coming down. That means they are responding. Imaging, if you repeat the bone scan, the hotspots are less in number. That is the response. There are some patients, after about 12 to 18 months after treatment, initial treatment, they shows evidence of recurrence. Recurrence can be again clinical, biochemical, or imaging. Clinically they get bone pain, biochemically the PSA starts to rise again, or imaging wise it shows bone mets, more hotspots. So that is called what? it's a escape. It's a hormone escape, and that is called castrate-resistant prostate CA. If the patient shows either clinical, biochemical, or radiological recurrence after initial treatment, after initial response to treatment, generally happens after 1 year, 1.5 years, that is called castrate-resistant prostate CA, right? CRPC. Then there is no, we have already given the androgen ablation, patient should be given chemo. I think docetaxel is a drug of choice with steroids.
That happens only in the medical castration or in both?
Both. It can happen after both. So that is called castrate-resistant prostate CA. So there's a trait that is a place for chemotherapy, docetaxel.
If medical castration fails, can we go for the surgical then?
Some people try both actually. Some people try both.
Like stepwise or
No.
Medical then chemo. Medical fails, we are going to...
Yeah, medical fail the chance. That means it is no longer sensitive to testosterone. That is the phenomenon, escape phenomenon. That is the reason. So there is no point of doing bilateral lockedectomy. Because bilateral lockedectomy, there are complications. Apart from local complication, testosterone protects you guys from what? Cardiovascular events. So the risk of MI also goes up once the testicles are not there. So it's important. Safeguard it. Already history confirm करगा तो BL होगा चलो. Why are we keeping the patient? Therefore,